Good afternoon. Thanks everyone for joining us today. My name is Bethany Hedden Clayton, and I'm the Federal Grants Manager at the Center for Behavioral Health and Justice, which is a community-based research center that provides local communities, organizations, behavioral health and law enforcement agencies across Michigan with technical assistance, evaluation, and support to optimize diversions of individuals from jail and prison through the implementation of best and innovative practices at every intercept of the criminal justice continuum. During our presentation today, audiovisual capabilities have been turned off for attendees to limit distraction throughout the presentation, but we encourage you to ask questions of our presenters. You can answer your questions. You can enter your questions in the Q&A box on your screen at any time, and we will address these questions as time permits during the Q&A portion at the end of the event. This presentation today will focus on the benefits of implementing harm reduction principles for behavioral health practitioners. We will have three presenters today: Mindy Vincent, Joshua McLenithan, and Emily Pasman. I think we can go to the next slide. Great. So Mindy is a licensed clinical social worker specializing in mental health and addiction treatment and is the founder and executive director of the Utah Harm Reduction Coalition. Mindy started the first legal syringe exchange in the state of Utah and has done extensive work in harm reduction, opioid overdose prevention, awareness and treatment, and continues to work to educate the community, stakeholders, and policymakers about harm reduction and expand services throughout the state. Mindy owns a group practice, Life Changes Counseling, in Sandy, Utah. She received her bachelor's degree from Utah Valley University and earned her master's of social work and her master's of public administration from the University of Utah. Joshua is the lead recovery coach at the Grand Rapids RED Project. He manages the post-overdose response wellness check program and the MOUD program within the Kent County Jail. He has worked for the RED Project for 3 years and is a certified peer recovery coach. Emily is not a PhD candidate, but actually Dr. Pasman, as she successfully defended her dissertation this past Monday in the School of Social Work at Wayne State University. Congratulations, Emily. Her social work practice is centered around the development, implementation, and evaluation of peer-delivered services for people in or seeking recovery from addiction. Her current program of research aims to expand harm reduction interventions, improve peer-delivered services, and promote effective youth prevention and recovery support. She examines stigma as a primary barrier to effective service provision in each of these areas. The goal of her research is to reduce overdose fatalities and other substance use-related harms by increasing access to evidence-based services. Mindy will begin our presentation with an introduction and background about what harm reduction is. Joshua will follow, who will describe several harm reduction programs he has implemented on the west side of Michigan. And Emily will conclude the presentation with barriers to implementing harm reduction interventions and strategies. After that, we will have a Q&A session. Mindy, go ahead and take it away.
Thank you very much. Sorry, it took me a second to unmute and uncover my camera. First, thank you so much for letting me be here today and letting me share a little bit about harm reduction. Before I share about the principles of harm reduction, I just want to share a little bit about how I came to do harm reduction, because I myself am a person who has recovered from a substance use disorder. I'm a graduate of felony drug court. I've been to treatment. I was a card-carrying member of AA for many years. And then when I was 7.5 years sober, my sister died of an opiate overdose. And my little brother was still addicted to opiates. And I was desperate to save his life. And that's the first time I realized in my years of practice that I wasn't doing the best job I could do at meeting people where they were at. And then that's how I ended up finding harm reduction. So with that, let me tell you about the principles of harm reduction. Next slide, please. So harm reduction is a set of practical strategies that reduce the negative consequences associated with drug use and other risky behaviors. It's often applied to sexual risk as well. When we take people into our syringe exchange program, we always do a sexual risk assessment with them so that we can target all the areas of risk. In relation to drug use, it incorporates a spectrum of strategies, including safer use, managed use, and abstinence. So substance use in and of itself is on a spectrum, and harm reduction is not against abstinence. It's on a different part of the same spectrum. So we have abstinence all the way over here, and then we have chaotic use all the way over here. And harm reduction is, well, it's everywhere because, it reduces harm, but it's somewhere more over here, I would say. Harm reduction strategies meet people where they're at, but we don't leave them there. And that's an important thing to remember, because one of the things that I hear most often in regards to harm reduction is, oh, you're just enabling them. But the reality is that with what I've been through in my life, both personally and professionally, I don't want to see people use drugs, but and I'm a professional, right? So if I'm not helping them to move through the stages of change, then I'm really not doing my job, right? So I can meet them where they're at, but I have to do the work to help them move along, or else I, as a professional, I'm not doing my job. Next slide, please. It's also risk reduction. We employ various strategies and approaches to reduce individual physical and social harms that are associated with risk-taking behaviors. And we all know that there's a whole spectrum of those. There's physical harms, there's mental harms, there's spiritual harms. So harm reduction gives us, viewing things through a harm reduction lens as a practitioner, gives me so many spectacular areas to help people make any positive change, because harm reduction really is about any positive change. It applies a holistic approach, similar to what I was just saying, and the degree of harm associated with a risk behavior varies upon a whole bunch of things. Usually when we talk about that, we're talking about drug set and setting. And I don't know what practitioners in Michigan exactly look like, but I know here in Utah, where I live, I don't hear practitioners speak about drug set and setting hardly ever. And I think we do a disservice by not addressing the many ways that you can be harmed. Like, for instance, if somebody's more emotional, they're more likely to overdose. If people are not eating, there's so many things, right, that play into physical harm alone, that I think it's important we address, and that's an important piece of harm reduction. Next slide. I said earlier that the thing I hear the most often in regards to harm reduction is that I'm just enabling people. The reality is I don't have the power to make somebody stop using drugs or start using drugs. But what I do have the power to do is to help people identify why they might be doing that, the harms that are coming to that, and maybe some alternatives for doing something different. So it's important that I just, kind of state what harm reduction is not. It does not mean anything goes. If I talk to my staff all the time about, there's an essay in public administration called The 1,000 Hands, and they talk about when somebody goes through the system, on average, they'll have 1,000 hands of us workers and helpers touch them, right? And I want the hand that I leave to leave a mark. And that is my obligation ethically and morally, right? So if I'm just high-fiving people, just not doing what it takes to help them move forward, then again, I'm not really practicing harm reduction. Harm reduction does not enable drug use or high risk behavior. I don't have the ability, like I said, to make people start or stop using drugs. When I used drugs, I never thought, oh, I don't have a new syringe, so I guess I just won't use today. Instead, I used old syringes. I have at times shared syringes. So when we're practicing harm reduction, we actually are able to provide those things so people do not they do not act in those high risk behaviors. We do not condone, endorse, or encourage drug use. Like I said, if I could make people stop, I would, but that's just not what my role is. It's not what I can do. It does not exclude or dismiss abstinence-based treatment models as viable options. People often view abstinence and harm reduction in competition, but they are not. I got sober through abstinence. I definitely love abstinence for many people, but I don't get to make that choice for other people. And as a practitioner, I don't feel like it's very client-centered to tell somebody right away, like, this is what you're going to do. We're going to take away your favorite coping mechanism, even though you don't have new ones to use. So I engage people in treatment no matter what their relationship with substances look like, because I believe if I help them learn the skills so they can do something different, that eventually they will. And if we could be abstinent, that would be, if everybody could be abstinent, that'd be great. Okay, next slide. So these are the principles of harm reduction. I think most of us practicing harm reductionists borrow the ones from the National Harm Reduction Coalition, which is where these are from. Harm reduction focuses on health and dignity. We establish the quality of individual and community life and well-being as the criteria for successful interventions and policies. In a treatment model, what that means is that when someone comes to me and says that they would like to change their substance use in any way, and they're able to accomplish that, that we have reached the goal that they were shooting for. I think later we'll talk about some other kinds of programs. And I mean, for syringe exchange, if I'm getting people to not throw used syringes on the ground, that's a successful intervention, even though people are still using drugs, right? But at least we're cleaning up the community. Harm reduction calls for participant-centered services, which is non-judgmental and non-coercive. This is sometimes very hard, especially when you're dealing with people who are in the court system. And because we have treated substance use through the court system for so long, it's really hard sometimes for people to let go of that punishment piece. But people are their own agents of change, and we know that. And we know that shame only changes behavior short-term, not long-term. So participant involvement, harm reduction ensures that people have a real voice in the creation of the policies and programs that are intended to serve them. In some other states, not where I live, but in California and New York, I don't know about in Michigan, but they have drug user unions. So people who are actively using drugs to participate in policy and program making. One of the things I love about recovery is, and substance use, is that the vast majority of people recover. We have a huge pool of people to pull from who have recovered from a substance use disorder, who have the knowledge that we're looking for, and who are in a place to be involved in a really healthy way. So participant involvement is huge in harm reduction. We have a whole spectrum of people to pick from to get the best programs for our folks. Next slide. Participant autonomy, very important in harm reduction. People who use drugs are their own primary agents of change. I would say people, period, are their own primary agents of change. So I really try to meet people where they're at and help them. You know, motivational interviewing, it's so important in the work that we do and in helping people find who they want to be and what it'll take to be that, and what are some of the things that need to change and where they need support. There's so many pieces to recover, to people recovering. There's so many places we can meet people where they're at, and they can make all their own choices for change. Sociocultural factors. I will try not to get off on a tangent on this one, but we recognize the various social inequalities which affect both people's vulnerability to and capacity for dealing with potential harm. You know, people not having housing, people being disconnected from family, from friends, from community, not having any purpose, all of those things, people having their kids taken away, all those things have a huge impact on whether somebody's even able to recover. Just like people who grow up in poor areas with less resources and in abusive homes with high ACEs scores, those people are also much more likely to become addicted to substances at some point. And if we are ignoring all of those things, then we're really not serving people very well. And it's one of the other things I really love about harm reduction is that it's not, in my own recovery, I was always just told if you want it bad enough, you know, and I knew a lot of people who wanted it bad enough who are dead today. And there's a lot of things that get in the way of somebody's ability to stay recovering. And we have to do our best to try to mitigate those things so that people can learn stress tolerance, so that people can manage things in a healthier way and not relapse. And when people do relapse, you know, we need to look at why that is and not just expect that everyone should be able to recover in the same way all the time, you know, because it just doesn't work. Pragmatism and realism. We do not attempt to minimize or ignore the true and tragic dangers and harms that come from substance use. And anybody who knows my story knows that, I've lost a sister. My whole family's been ravaged by opiate addiction. I myself was a meth addict. I lost my son twice. Like, I mean, drugs have so many harms, and I would never ignore those. And they are some people's best way of coping at the time and the only one they know. And my job is to be here, to love people, to help them, to give them the tools that I know of that can help them, and to help them try to discover new ones inside of them. But always while letting them know, like, hey, things can be different. Like, this is going to be a bad choice. If I don't tell people, like, you're heading down a pretty bad path, then again, I'm not doing my job. Right. So I think that is it for me. So I guess I'm going to turn it back over to Bethany. Thanks for letting me be here. I'll see you at question and answers, friends.
Thank you, Mindy. All right, Josh, let's pivot to you.
Hi, I'm Josh from the Grand Rapids Red Project, our lead recovery coach, and I am going to speak a little bit about the programs that I do for the Red Project. Next slide, please. So since working at the Red Project, a couple of the programs that I do are the post-overdose response program, also known as wellness check program. And so what that is I get all referrals from local EMS, emergency services, as well as police departments. Anytime Narcan's administered to anyone for any reason, I receive those referrals, and I do what we call a wellness check on the individual based on a incident address and a resident address that I am given. And how I implement harm reduction is when I follow up on folks who've recently experienced an overdose. I myself have experienced overdose personally. I know that it is a very sensitive time for somebody, and that it is not a time to be showing up at someone's door with multiple people, people in suits, a police officer, anything like that can be spotted from a mile away. I come to an individual's house with a backpack full of Narcan and fentanyl testing strips, because I recognize that just because somebody has recently experienced an overdose doesn't necessarily mean that they are ready to stop using or be in abstinence-based recovery. My personal recovery is abstinence-based, but I also recognize that recovery is different for everyone. And at the very least, when I'm following up with somebody that's recently experienced an overdose, I can come bearing gifts and maybe planting a seed. And as a recovery coach, my goal is working to improve someone's quality of life in whatever way that may be. And when I'm following up with folks, like I said, I come with a backpack full of Narcan and fentanyl testing strips, because that day somebody may not be ready to, let's say, stop using, but they might be interested in potentially going into a medically assisted treatment program. Or maybe they might tell me that they're struggling with food, they're having issues getting clothing, they don't know where to start. And they don't have to tell me right then and there, but I will tell them about what we do at Red Project, and how not only can we assist you in helping with those things, but also we carry all the harm reduction supplies that you may need, whether it's sterile supplies, syringes, pipes, Narcan, fentanyl testing strips. You can come and get those anytime that you want. And I know from experience that, and as Mindy had previously said, just because you may not have a syringe doesn't mean you're just going to stop using that day. You'll reuse one and reuse one. I still have a needle tip broken off in my arm from back when I was using. That's how desperate I was at the time. And I realized that folks may not be ready to stop using, but at that moment, we can help provide them with the supplies that they need to stay healthy and stay alive, and reduce the risk of spreading disease potentially. Another program that I also do is the jail MAP program within the Kent County Jail. So what this program is, uh, first of all, if an individual is receiving medically assisted treatment such as Suboxone or methadone prior to being incarcerated, they will still receive those medications within the Kent County Jail, which is extremely unique, considering most jails or correctional facilities will not allow you to receive these medications and will unfortunately just let you detox in a jail cell. So the Kent County Jail has implemented this program where folks will not only receive that medication, but they will also be connected with myself, a recovery coach, while they are incarcerated. And what we do is we work to set up goals and work towards post-release success. I've personally experienced incarceration in jail, prisons because of my substance use. And every time I was released, there was nobody there for me. There was no resources that were provided to me. There was nothing. I would go back out to the same streets that I was in before I was incarcerated. So with the jail MAP program, what I do is I meet with folks on a weekly or bi-weekly basis, depending on their release dates and sentencing, uh, things of that nature. And we will discuss goals and setting up housing resources such as recovery housing. A lot of folks will come in and have nothing, have nowhere to go, and we will make sure that they have recovery housing set up for them upon release so they have a place to go. Not only that, we'll make sure that their medications are continued and that they don't have to go through any withdrawal or any lapse in period without receiving that medication upon release. And then we will also connect them with resources for food, clothing, as well as transportation, whether I personally provide that transportation, whether we provide wave cards, which are our local bus passes here, that will all be provided to folks as well, free of charge. There is no charge for any of our services. And we also have a case manager who works within the jail and is kind of my person on the inside that will also meet with folks on a weekly basis, and we coordinate together to set up everything we can to make sure folks have post-release success. Again, as I was saying, a lot of individuals that are experiencing incarceration are being released to nothing and expected to not kind of come back in that revolving door of the justice system. It's set up for folks to fail, and we are doing what we can to make sure that they are not coming back to jail. And also we have been inducting folks on Suboxone 6 weeks prior to their release. Folks that have expressed to us their concerns about being released, falling back into substance use. So even if they were not on an MOUD of any kind prior to incarceration, we can still get folks inducted on Suboxone prior to release, 6 weeks prior to their release, if they express to us that they are concerned about being released and going back into the maybe the place where they're going is not a healthy environment, but it's the only place they may feel that they can go if they're not interested in going into recovery housing or going into a treatment program. It's kind of up to the individual where they choose to go. We don't force anything on anyone. We just lay out the options and try to see if we can help better improve their situation. So with that induction of Suboxone, we are able to kind of help folks that might feel that they're going to struggle if they're released, and it kind of gives them a safety net upon release. And then also once they are released, they're connected with me through in their property bags. They not only are they meeting with me weekly, so we've developed a relationship and they feel comfortable speaking with me and meeting with me, but also in their property bag are is Narcan is provided to them, because we also recognize, like, hey, I know what it's like. About 99 times out of 100, when I got out of jail, I went and used again, until the last time that I chose not to. It's all up to the individual. You can't tell anybody to do anything. We just like to lay out these resources for folks and say, look, you have this afforded to you if you need anything. And I always express to people that we are not an abstinence-based program. You can reach out to me the day you get out. If you decide to use, if you decide not to use, doesn't matter to me. I just want to be there to help you better improve your quality of life, whatever that looks like. And for me as a recovery coach, every day, that's different. I sometimes take people to get a driver's license or a state ID, because it's simply something they have not been able to get on their own, and that may have prevented them from getting a job. So right now, I've just removed a barrier for somebody that now they might actually go and look to get a job. They have that state ID that they've needed that's prevented them in the past from getting work. And now we've assisted in some way to remove those barriers for folks. So with that said, those are the programs that I currently do within the RED project, on top of just being an everyday kind of recovery coach. I was just thinking about, as soon as I'm done with this, I immediately have to go meet a client that I met through the jail program to help her get to see her probation officer. And if I weren't able to provide that transportation, they would have no other way of getting there. And to me, that is just removing a barrier for somebody. And if that's what I do on any given day, then I'm doing my job, and we are helping people improve their quality of life. And I think with that said, I can pass it off to Bethany, and thank you guys for listening. I look forward to the Q&A.
Thank you, Josh, for bringing to life the principles that Mindy introduced us to. Now we'll hear from Emily.
Everyone, thank you so much for having me today, and for everyone for your time and attention today. It's really an honor to be a part of this webinar, especially along with Mindy and Josh, who are doing such important work in this area. We've heard a lot so far about kind of the benefits of harm reduction services, and I'll be wrapping up by talking about why we don't have more of these services, and I attribute a lot of that to stigma. But before I jump in, I did want to provide, like Mindy did, a little bit of background on why this topic is important to me. I worked in peer-delivered recovery support services for several years, and during that time, I really did not have a lot of exposure to harm reduction, and really didn't become interested in harm reduction until the first year of my doctoral program, when I helped with a study that took place at a methadone treatment program. And that was just such a transformative experience for me, because I really saw how stigma impacted services and realized that I had a lot of my own misconceptions. And the more that I learned about harm reduction, the more I realized how valuable this approach is. And I really became dedicated to doing kind of my little part to address stigma and expand access to these types of services. Next slide, please. So stigma is a process through which negative stereotypes are assigned to a group of people, resulting in prejudice and discrimination. So it's important to understand that stigma is not just negative beliefs, it's also unjust treatment at the individual and systems level. A person can be stigmatized because of their health condition, for example, because of their drug use or their substance use disorder, but they can also be stigmatized because of their association with a particular intervention, like a type of harm reduction service. So although harm reduction is really considered a key piece of drug policy and practice in other parts of the world, services tend to be very stigmatized and underused in the United States. And we know that both people that use harm reduction services and people that provide harm reduction services experience stigma. Next slide. So one of the main reasons that harm reduction services are stigmatized is because drug use and addiction are very stigmatized. And it's pretty consistently shown that people that have negative attitudes towards people who use drugs tend to be less supportive of harm reduction services. But a person doesn't necessarily have to stigmatize drug use and addiction in order to stigmatize harm reduction. For example, some people may not have negative attitudes towards people with addiction and may be very supportive of abstinence-based treatment, but at the same time opposed to harm reduction services. Some important context to kind of recognize here is that in our country, most substance use services are abstinence-based, meaning complete abstinence from all non-medical substance use is considered the primary goal of services. Now, this is not necessarily a desirable or realistic goal for all people. Mindy did a really good job of explaining this and kind of why harm reduction can be beneficial. But many people equate recovery with abstinence and really see anything other than abstinence as unacceptable. And then finally, because our substance use service system is really dominated by these abstinence-only models, very few people like myself had knowledge or exposure to harm reduction interventions. And that lack of knowledge can really lead to misconceptions that drive negative attitudes. Next slide. So I'm going to run through some examples of kind of how we see stigma play out. So first, I'll talk about stigma toward harm reduction among members of the general public. This photo that I have here is from a news story that was about a billboard that recently went up in DC opposing safe consumption sites. So for those that aren't aware, safe consumption sites are facilities where people can use drugs under the supervision of trained staff who are then there and able to intervene if there was an accidental overdose to occur. Now, in this story, this is a parent of a person who uses drugs, and she's asking Biden to support recovery, not enablement. So concerns about these services condoning or enabling use are common. Mindy touched on this a bit. But a really common concern, for example, that we hear about naloxone is that it might unintentionally condone or encourage risky behavior. This is actually not supported by the evidence. We have research that shows that naloxone distribution programs do not lead to increased drug use, and actually people who receive training on naloxone are more likely to reduce their use than to increase it. Concerns about enabling are also really unfounded. So this idea that a person has to hit rock bottom in order to succeed in recovery is really a myth. And what we actually see in the research is that people that have more resources and more support are more likely to recover, which really makes sense when you think about how difficult recovery might be for someone that has no home or no family support or transportation. We also see a lot of not in my backyard or NIMBYism around harm reduction services. There's a lot of people that maybe support these services generally, but not locally, don't want them in their neighborhood. And this is really tied to concerns that services might lead to increased drug use or crime in the area. But again, these concerns are really unfounded. Research shows services do not increase the overall prevalence of drug use or crime in the area, and many have actual positive community benefits. For example, safe consumption sites can lead to less public injecting. Syringe service programs lead to less littering because they provide that proper opportunities for proper disposal of syringes. However, these types of negative attitudes are really common among the public, and it is a concern because public sentiment does really drive public policy. Next slide, please. So we also have research that shows that unfortunately many substance use treatment and healthcare providers have these same types of negative attitudes towards harm reduction that we see among the general public. So beliefs that maybe these services are ineffective or enabling. This graph that I have here is from a study of treatment providers' attitudes towards medication for opioid use disorder. And we found that many treatment providers in Michigan actually do not consider agonist medications effective. So only about half considered methadone effective. And that is the medication that is actually backed by the strongest evidence base. We also had only just over half that agreed that long-term use is effective, even though research shows that kind of longer retention in treatment is associated with improved outcomes. These types of attitudes among treatment providers are very concerning because providers are really supposed to be the people that are the most knowledgeable about these services, and they also have a huge impact on access to services and quality of care. So for example, providers that have kind of negative attitudes towards harm reduction tend to be less likely to provide or connect people with these services. They might also be less empathetic and engaged with people that are using a harm reduction approach. And when people, when clients or patients kind of have these types of negative experiences with providers, that can lead them in the future to kind of put off seeking help or withhold important information from their providers or even discontinue treatment. Next slide. And then when stigma is internalized, it can really affect the recovery process. So there's something called the why-try effect that really describes how stigma affects self-efficacy and goal-related behaviors, including kind of health and recovery intentions. So people who use drugs who believe these negative stereotypes about themselves might feel unworthy or unable to really take charge of their health by using harm reduction strategies. And this can really discourage them from seeking services. We also know that many people who use drugs are hesitant to carry naloxone or to take agonist medications because of the stigma that's associated with harm reduction services. Next slide, please. And then we also see stigma at the policy level. So one example of that is the funding that we have for harm reduction in this country. We have very little. So the American Rescue Plan Act of 2021 was the first time that the federal government provided funding that was specifically allocated for harm reduction. And this was obviously a very exciting and important step in the right direction. But when you really take a step back, it was really a drop in the bucket. So harm reduction received less than 1% of all funding that was provided for substance use services, and the vast majority went to prevention, treatment, and recovery programs, which are all kind of typically abstinence-based. We also saw really stringent regulations surrounding how this funding could and could not be used. Some of you may have seen there was a bit of uproar around whether Biden was going to be purchasing crack pipes for people, and that ultimately led the administration to prohibit this funding from being used to purchase pipes for smoking kits, even though smoking is a safer alternative to injection. And then finally, some harm reduction services are just outright illegal. So safe consumption sites are still illegal in this country at the federal level, and many states have laws against syringe service programs and fentanyl test strips. So obviously that criminalization is an obvious barrier to service provision. Next slide. Now, I feel like I've been a bit of a bummer, so I'm going to end with a few things that we can all kind of do to reduce stigma toward harm reduction. At the individual level, those of us that are supervisors, we can include questions about harm reduction philosophy in the interview process and really try to select staff that are supportive of this approach. Supervisors can also work with our current staff in supervision and help them really process and manage their personal reactions to harm reduction philosophy. Those of us that are clinicians, I think it's important to understand that many clients that might benefit from harm reduction services are likely affected by stigma. So this is something we can kind of bring up in counseling and help clients kind of find ways that they might cope with that. I think there is a ton of power at the agency level. So agencies can decide to provide services, harm reduction services on site, or at least develop processes for referring clients to other local harm reduction services. Administrators can encourage and support staff in attending trainings in harm reduction. And agencies can also consider discontinuing punitive sanctions for drug use. This can be really stigmatizing and shaming, and research actually shows that it's not a very effective strategy. At the systems level, we can all really be advocating for policies that make these services available in mainstream healthcare settings. So some examples, we're super close to having naloxone available over the counter in the US right now. We're also seeing a lot of movements around loosening regulations surrounding methadone. I was just reading a paper about a Canadian hospital that opened a safe consumption site on hospital premises, and it was actually very successful. They had over 11,000 visits in the first year, averaged about 26 visits a day. So we can support movements to have really accessible mainstream harm reduction services like that in the US as well. Another policy issue I wanted to bring your attention to is that people taking methadone or buprenorphine are sometimes denied psychosocial services, for example, like not allowed to live in recovery housing. And this is actually a violation of the Americans with Disabilities Act, which is really supposed to protect people with opioid use disorder from this type of discrimination. So we can all be really advocating for appropriate implementation and enforcement of that law. And then I'll just end by encouraging everyone to sign up for alerts at drugpolicy.org. They will send you email notifications about policy advocacy opportunities. I find it a good way to kind of stay informed about legislation in this area, and they make it super easy to contact your legislators about the various policies. So with that, I will turn it over to Bethany, and I look forward to hearing questions and comments from you all.
Thank you, Josh, Mindy, and Emily for presenting today. We really appreciate it. At this time, we've arranged for questions to be answered. Please put your responses or further questions in the Q&A box. If we don't get to your question today, or you want to be connected to any of the presenters, you can email us at cdhj@wayne.edu. In addition, a recording of this webinar and the slide deck will be sent to all registrants. And from there, let's see, our first question, we have some already in the queue, so I'll just take us through what we've got so far. Our first question comes from Mark, and I'm going to ask this of Mindy, but anyone is, Josh and Emily, you're more than welcome to chime in as well. So Mark is really wondering kind of about the social relationships surrounding engagement and uptake of, I think, harm reduction practices, and specifically wrote, granted, people are their primary agents of change, but can others be a secondary agent of change? Can you share a little bit about that question, Mindy?
Definitely. Like, people can definitely be secondary agents of change. I think as practitioners, we have to be careful about how we be that. Like, one of the best things I get to be for people today as a practitioner and a person who's recovered is I get to be an example of what is possible. But I also get to be that safe place that they can come to for help, and I'm not going to cut it off based upon what they are or are not doing, right? Which is what we do throughout this entire country. What we typically do when someone relapses is we cut them off from care. That is getting a lot better, but it's completely contraindicative clinically. And so as long as I'm being a secondary primary agent of change through non-shameful methods, then it absolutely falls in with harm reduction. Harm reduction has lots of peer stuff too. Peer stuff is huge in harm reduction, which I think is because of that connection piece, right? And we know from the research that clinically our rapport is what helps make change. And so I could go on all day about that.
Well, Mark can follow up with you if there's more to be said there. I'm sure there is. There are two participants that were wondering about funding, and I'm going to ask Josh, direct this question to you. One participant specifically asked, how's the RED project funded? So if you, and specifically, I think I'm going to just tie the second question in. There was another participant that said they hear there is funding through the courts for clients to get into an MAT program or treatment of some kind, but no one tells you how to go about obtaining this funding or letting the courts know about your program. Do you know how a treatment program can go about this? So if you can speak to maybe the post-overdose response work and how that's funded, if you can illuminate that, and then also the MAT stuff you do.
Yeah, sure. So more directly, RED Project is funded through grants and donations. That's it. And when it comes to like the post-overdose response program and the jail MAP program, originally those were funded through Wayne State, provided a grant through RED Project, and we use that for both programs, post overdose response and the jail MAP program. The second part of that question in regards to the court and kind of what they provide, I don't want to give any misinformation. I don't know about the court side of things. We get grants for these programs and we implement that within our organization and work directly with the case manager and myself within the jail. The court system is a little bit of a separate entity. At most, what we will do is we can write letters to judges of support and things for individuals, but when it comes to what they provide or the funding for anything else, I don't know.
Thank you, Josh. I lost where my mouse was. So I appreciate your answer on that. Appreciate it. Okay. Our next question comes from Ashraf. They're curious about barriers to service engagement. Emily, I'm going to give this one to you. You talked about stigma as a barrier. And they asked, for someone who would like to pursue a healthier lifestyle free of drugs, what are some implications that can deter a person from seeking help? For instance, a person who is interested in becoming clean but is not ready to abandon the substance immediately. Oh, and Olivia's so on it. It was categorized to a different category and I lost it. They were asking about the possible legal ramifications, if I'm remembering correctly, legal concerns about sharing that they are in active use. So if you want to speak about that, that'd be great.
Yeah, I think that is legal concerns specifically are kind of a major deterrent to harm reduction services. And we do have kind of a lot of protections that are supposed to be in place, like the Good Samaritan law is supposed to protect you if you witness an overdose and call for help in an overdose event. You are not allowed to be arrested as long as you're seeking that medical attention. But there's still a lot of distrust in the criminal legal system where people don't believe that they will be kept safe. Same with even syringe service programs or safe consumption sites that we have in other countries. A lot of people have fear of using these services, even though the services themselves might not be illegal. They know if they're seen accessing those services, they're going to be kind of labeled as an addict and could be targeted by the police. So I think that is a major concern. And then even like the person who asked the question, the way they asked the question, saying like a person is not ready to, completely give up use. I think that is can be a huge barrier to people for a lot of different types of substance use services. And that's just why harm reduction is such a good approach, is because we don't expect people to give up everything all at once, because all the research that we have on substance use and the change process shows that that's not how people make changes. Changes occur in really small steps, and asking people to give everything up all at once is very scary. So I think that can be a major barrier as well. I hope that answers your question.
Thanks, Emily. Our next question, I'm going to offer to, let's see, I think this is an all question. I'm not quite sure. Matt brings this question. He's talking about harm reduction in the context of caregiving relationships and asks specifically, with harm reduction efforts to use non-coercive efforts, what is a harm reduction approach when a primary caregiver of a young child is also involved with substances? How does harm reduction balance the safety of all parties, not just the person who is involved with substance, with the safety or with the principles of practicing harm reduction? Yeah, whoever kind of wants to go to that. I'm not sure between the three of you. I think all of you have something to say about that.
Yeah, there's laws around that. I mean, as a licensed professional, I have to protect children, but not everybody who uses drugs is a danger to their child. And not everybody who uses drugs neglects their children either. So, and harm reduction does not mean no consequences, right? So we work with people to say like, hey, this is the harm that could come if we don't change this behavior, because now you have a system involved in your life, right? And the systems are not as understanding about substance use as a practitioner is, right? And so we have to work within those frameworks, but also, I mean, I don't know what it's like in Michigan, but here in Utah, we do try to keep families together as much as possible, and try to do in-home services, which I would very, very strongly encourage, because people who have their children removed from them are at significantly higher risk for continued substance use, for overdose. That doesn't even include the trauma to the child of being separated from their parent, because even when a parent's not a great parent, it's still traumatizing for the kid, right? So there's a lot of things to consider. And a child's safety, of course, is always at the top, but we have to remember that the things that people say are not necessarily true. Like everyone who uses substances shouldn't be a parent. That's just not truth.
Thanks, Mindy. Josh, Emily, did you want to add to that? It's okay if you don't. We have other questions, many more questions to get to.
I mean, I'll just say, like, I really like what Mindy said. And I think that we just need to think a little bit more holistically about, like, you know, what does parenting look like? Like Mindy said, like a person can use drugs and be a good parent. And a lot of times removing a child from the home is going to cause a lot more harm than a child living with someone who uses drugs. And I think we need to just think about it with a little more nuance. An area I'm really interested in too is the criminalization of substance use during pregnancy. It's, you know, not always harmful, or it's more harmful sometimes, the laws that criminalize substance use in pregnancy than substance use itself, because people are so scared of losing their kids. No parent wants to lose their kids, that they're not going to seek out help. They're not going to seek services or care if they think that their kids are going to be taken away from them. So I think that's a great question, and Mindy's response was great.
I'll also add that not all substance use is chaotic substance use, you know, and I think that's a common misconception that if someone's using, it's chaotic and therefore they should lose their children. And that's just simply not true. I work with clients every day that are maintaining healthy lifestyle, healthy relationships with family members, and they still actively use. So I think that misconception that all substance use is chaotic is part of the problem as well.
Yeah, complex question and met with a complex answer that elicited more nuance. So thanks, presenters. Okay, our next question I'm going to direct to Mindy and Emily. This comes from Mark, who asked about safe consumption sites, named specifically stating they haven't been taken to scale. Correct? Yes. Model programs frequently have difficulty going to scale. Does this concern harm reduction advocates?
You want to go first, Emily?
Sure, I can. So I'll just say that these sites have been around for decades across the world. We have almost 200 sites that are in operation across 14 countries across the world, but we only have 2 in the United States. Both are in New York City, both opened just over a year ago. These sites are still prohibited under federal law right now, which I think is a lot of the reason that we don't see more of them in the United States, but hopefully we will be seeing more, because we do have these 2 sites in New York that have been successfully operating without interference from the federal government. So I do think that's like the next big thing on the harm reduction kind of scene, if you will. I think that we will be seeing more of these sites around the country soon.
And I would just echo what Emily said, that stigma is the thing that really gets in the way here in the United States. There's been a lot of city councils, governments that have passed to have overdose prevention sites, pilot programmed, and people come in and they're like, not in my backyard, and they put pressure on the landlords to pull the leases. They do a whole lot of things to try to stop these, because they seem so enabling. But the reality is that of those over 200 safe consumption sites in the world, millions and millions of injections, smokings, all sorts of things have happened in them, and not one person has ever had a fatal overdose, which makes overdose prevention sites more effective than even naloxone. And if we're serious about preventing overdose, then we have to look at these kind of options, and we have to get our own biases and stigmas out of the way, because the research clearly demonstrates that they're effective. And I've been to the ones in Switzerland, and in countries where they have them, the community gets together and says, hey, we actually need more of these, because they clean up the community. There's all sorts of rules around them. It's not just a free for all. Like they even have rules around how many people can be accessing the safe consumption site and taking the bus, right? Just to help the community feel more at ease about it. They're medically driven programs. People just have to realize they're not the nightmares that they think that they are, which has been my experience in harm reduction, period. People, sometimes you just have to push forward, open the program, and then everybody's like, oh, I guess that's not what's going to happen. You know, it doesn't look like a scene from Saw in here. Like, and that's what we just sometimes have to do.
Thank you. All right, Josh, I'm going to give you this next question. Comes from one of the participants that's asking about, I think, really centering how the axiom of dead people can't recover and the principle of harm reduction to save lives. And so this person said, unfortunately, it feels like we are at are lost with the ultimate goal, which should always be, how can we stop people from dying? When this is our goal, the view on harm reduction strategies seem to change. I'm wondering if you can speak to that, but I would say beyond that, how do we also get people to care that people who use drugs are dying? Because I think that's also a part of the barrier to harm reduction, is that some of these deaths and the people living these lives, those lives are devalued, unfortunately, in a society that stigmatizes and criminalizes drug use and people who use them.
And that's the thing, all overdose deaths are preventable, but with the question that was proposed, I mean, that's part of the stigma, isn't it? Because we're talking about how do we stop people from dying? Well, part of the stigma with substance use is people use alone. It's, people are kind of using in these, substance use is so stigmatized that people end up using alone and they end up dying alone. And how do you prevent that? It's by recognizing that substance use is in every family, every person. I see a lot of people talk about how substance use doesn't affect them because they themselves don't use. And I do OD trainings all the time for organizations where I meet people face to face who will tell me they don't want a Narcan kit that I'm trying to give to them. And I have to explain, while you may not feel that you need it, I promise you someone in your family or a close friend does. And I think that it's the belief that people, well, I guess it's just really difficult for me to express how stigmatizing it is, because I used alone all the time. I never wanted to use with anybody. I was always at risk of overdosing and dying. And I think, unfortunately, that is still the case. All we can do is help educate the community. When I do these post-overdose responses, I always come with Narcan, fentanyl testing strips, and my business card saying, if you need anything, you can reach out to me. We're not abstinence-based. If you need help with anything, reach out.
Thanks, Josh. So I'm going to disappoint some people here. We're not going to get to every question. I'm going to choose to actually not go in order and flip to this question about funding, which I really think speaks to sustainability and scalability of harm reduction. And I'm going to combine two of these questions here and not read them verbatim just for time, because we are 2 minutes to close. This is for anybody. I think that some of the attendees are wondering about what mechanisms legislatively would support and codify into law harm reduction practices so that organizations such as Red Project and others aren't doing the grant writing dance, which we know can be a way in which to get programs kicked off and can be really great, but they're not guaranteed funding. And so I'm wondering if there's thoughts that any of you have about how to really make sure that this type of work is protected in legislative and financial budgets.
This work should be able to be built out just like any other treatment service. And that's just how it should be. Like when I'm doing syringe exchange and when I'm doing resourcing and stuff, I am doing case management, the exact same as I am for somebody who's enrolled in my treatment program. Also for my organization, because I'm a clinician, treatment is, I'm a treatment provider. And so adding a harm reduction based treatment program to our syringe exchange program, because syringe exchange got started first, that's been a way that we've been able to generate our own funding it's guaranteed because we earn it, because I don't want to be beholden to grants, because grants are so, you can't buy syringes with grants. That amount that Emily was talking about that they put out in funding, oh my goodness, that was the most highly competitive grant that it would, organizations like mine are going up against the New York State Health Department. Get out of here, and there is no funding. And often harm reduction legislation has a hard time getting through if it has any funding earmarked or attached to it. So finding ways to generate revenue and remembering that all the work that we do, it's social work and it's billable. It's billable to insurances and it's billable to Medicaid. I don't know for sure how your Medicaid works there, but I feel like it has to be better than here. So look into those.
Awesome. Thank you, Mindy and Josh and Emily, for your expertise, commitment to community, and passion for serving others. Thanks everyone who joined us here today. Like I said, this recording will be posted on our website and also emailed to you along with a slide deck. Please keep an eye out for future events, namely our upcoming webinar on methamphetamine, which will be in April. Thanks and be well, everybody. Bye.